we tend to trust who's, people, more than we trust what's, machines. And this is the first time we've had a what that acted like a who.
Dr. Robert Wachter is a national leader in healthcare quality, patient safety, and digital health, whose work helped define modern hospital medicine.
It'd be like if you had a baby, you spent all the time feeding and changing the baby and it never smiled at you. We got so little useful information.
As chair of medicine at the University of California, San Francisco, he coined the term hospitalist, igniting a movement that revolutionized hospital care around the world.
Predicament we're going to find ourselves in for the foreseeable future is it's right often enough to be useful and wrong often enough that the human has to look over its shoulder.
We explore his new book, A Giant Leap, and his vision for how technology and innovation and AI can chart a better path for patients and caregivers alike. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine.
I'm so looking forward to our conversation. We have so many things we could talk about, but I'm particularly excited because you have just published a new book.
I have, spent the last 2 years thinking hard about AI and where it leaves us, and it seems like the most interesting topic in the world, so it was really a lot of fun.
Yeah, it's something, of course, that we at Stanford spend a lot of time thinking about. It's not your first book.
It's my fourth sort of trade book, lay-oriented book, and I've done a couple of textbooks when there used to be textbooks.
Yeah.
So,
we used to have those, didn't we?
Yeah, we used to have those. But yeah, this is the fourth book I've written for kind of a crossover audience. I hope it's useful and interesting to health professionals and technology people and all that, but also for lay people interested in what happens to the world of healthcare with AI.
I was really interested. I mean, one of your previous best-selling books, The Digital Doctor, kind of in many ways sets up this current book, and I'd love to dive deeply into that. But it's interesting to me that you've written a book about the digital doctor, you've written a book about AI and medicine, but you don't describe yourself as a technologist.
Well, I have an iPhone, and I use it, so I'm pretty proud of that.
Yeah, that's pretty good.
I really do not know what's happening under the hood of any of these technologies. I got interested in technology because I'm very interested in the health system, what makes it work, and because I've been doing a lot of work in patient safety for 15 or 20 years. And therefore, you couldn't work in patient safety without believing that if we could just digitize, life would get better. And then we digitized, and in some ways, life got worse. And that got me very interested in the topic.
Well, that's actually the first thing I wanted to ask you about, because so many interesting and really resonant parts of the book. I've been listening to it on audiobooks over the last couple of weeks, and you read the audiobook yourself.
I do.
So it's been great to have you in my head.
For 9 hours, really?
Yeah, you're in little short segments at a time, an hour at a time. But you made this point that have made many times that so it really resonated with me, which is that some of the problems that we're trying to solve currently in medicine, and maybe even many of the problems, were actually created by a prior technology revolution, the one you wrote about in The Digital Doctor, which is the digitization of our electronic health records. But I'm really excited and quite optimistic, as I think you are, that the current technology revolution can actually solve some of those problems that were in a way created by the prior. But can you talk a little bit about that?
Yeah, I mean, this book is pretty optimistic, and I've had people ask me, is that just who you are? And I say, no, I'm fully capable of writing a very pessimistic book because The Digital Doctor is quite grumpy. I've been waiting for this technology to enter our world. You know, the book really is about us going from being a paper industry to a digital industry. And I think it made all the sense in the world that this was going to make care better and safer and more convenient and better for doctors and nurses. And then I found, burnout rates skyrocketed. Doctors were, unhappy with their electronic health record. So it was really my effort to understand why we had gone off the rails. And I think I came to understand, first of all, that any general purpose technology, a technology that just changes everything, they almost never meet their hype in the early years. And part of it is because version 1.0 is not very good. But part of it is that humans tend to just take that technology and just download it into their existing system, their cultures, their governance, their workflow, and lo and behold, it doesn't work. And when you see these technologies really pay off, and I'm talking about the steam engine or the car or the computer, it really takes sometimes a generation of the industry saying, why are we doing it that way? Oh, it's because we always did it that way. The unforeseen consequences of the electronic health record included now doctors could be prompted to enter data that created a better bill. And so, sure, let's make the doctor document that they counseled the patient about seatbelts or examine 9 body parts. And lo and behold, you turn the doctor into an expensive, grumpy data entry clerk. And then a few years later, we turned on this thing called a patient portal. And it gave patients all this data. I could see that my magnesium is low and my EKG is abnormal, but absolutely no help in interpreting it. And the only bit of help we gave them was a little button at the bottom that said, click here to send a message to your doctor. And lo and behold, patients being normal, click there to send a message to their doctor, and the doctors have 2 hours of pajama time. So those were the sort of things that are obvious that they're going to happen, but I can tell you in real time, I didn't predict them happening. And I think the bottom line was that the electronic health record became a useful and definitely positive big filing cabinet.
Well, you
did not deliver on the kind of clinical intelligence. And it'd be like if you had a baby, you spent all the time feeding and changing the baby and it never smiled at you. We got so little useful information and we spent so much time putting stuff into it. That's where the frustration came from.
Yeah, you write about it very elegantly. One of the stories that I thought was very funny was that you'd admitted that at the beginning you'd spoken to an informatics colleague who you'd sort of believed that their job wouldn't be necessary in a year or two.
Actually a Stanford trained informatics doc who we hired to be our chief health information officer. It was right after we implemented Epic. And I said, I figured out it could be a couple of years of tinkering and improvement. And then I said to him, and what are you going to do after that's done?
What is your career plan?
The stupidest question in the history of the world. He's busier than ever today.
Yeah, absolutely. So then that's kind of the setup in a way. And I think we've all spent a lot of time kind of apologizing to our people or trying to point out the fact that there were some benefits to the electronic record. I mean, you could for the first time actually get x-rays and lab results and some local electronic records that could be there in front of you. You needed like 50 clicks to find them, but at least they were there. But I think what we were waiting for was a technology that could potentially ingest all that multimodal data and potentially provide some partnership, some wisdom. And I think that somewhere just in the last 2 or 3 years, as GPT came to the fore, maybe the origins of the potential for that next revolution were there. And that's what you spend most of the time in the book talking about. And you talk about really accessing GPT from 2.0, I think.
Maybe 2.5 or something when I first tried it. Yeah, even then, it was in some ways awful because it did hallucinate a lot and all these kind of crazy things that told you to put glue on your pizza to keep the cheese on. Just sort of crazy, very caricaturizable, almost cartoonish problems. But nevertheless, it was obvious to me that here was a technology that was more human-like than anything I'd ever seen. And if you think about where we went off the rails with electronic health records, I just came to believe the first stage was going to be digitizing the record. The second stage was going to be connect the parts and interoperability. But we had not hit the really meaningful stages, which are, all right, you have all this data, how do we analyze it in a way that's useful, that helps us understand our patients better, and then how do you turn that understanding into actions? And part of the challenge was until GPT and the like, a lot of the data in the electronic health record is in narrative form. It's in your notes and my notes. There was no mechanism to deal with that. And even advanced technology tools like Google or like UpToDate, if you said to it, I've got a 62-year-old woman who comes in with breast cancer, she's got a calcium of 11 and a creatinine of 3, and she's got an infiltrated chest X-ray, what do you think is going on? It would the tools would say, are you kidding me? I have no idea what you're talking about. These tools, you could talk to it essentially like you would talk to a consultant. And as a generalist, I spent a lot of my time when on the ward sort of hoping to run into my favorite consultant, because every patient I take care of, I can name 5 people in the building who know more about each problem than I do. I know more about all of it than they do. So now in my pocket, I have subspecialty-level expertise that I can access and talk to like I would talk to a consultant. That to me was a remarkable technological advance.
Yeah, no, I think it was the human nature of I think the responses. Because in the end of the day, and you said this in your excellent Grand Rounds talk that we just came from, we all got used to thinking the Google search was kind of the best answer we could get. And it was pretty good, but at the end of the day, that's a series of links to other information. The interesting thing about the language models is, of course, they respond in prose and poetry.
And it's not just the output being links, but the input, if you put into Google really more than a single transactional sentence.
Yeah.
I mean, you can put into the Google what is the right dose of Eliquis for a patient with PE.
Right.
You could not put in the complexity of a real patient.
Yeah.
And so there's a risk of it being so human. One of the things I wrote in the book is we tend to trust who's, people, more than we trust what's, machines.
Yeah.
And this is the first time we've had a what that acted like a who,
right.
which creates a risk that we will give it undue trust. And we've got to be very careful about that.
Yeah, this is something I've actually talked to our residency program directors about, because obviously a lot of what you and I do is think about education, and really important in terms of our up-and-coming medical students and interns, and really all of us as doctors who are in continuous learning. We are built, especially when prose is very well punctuated, when words are used in a complex manner, when a concept is well articulated, part of your brain is trained to sort of switch off a little because of trust.
You trust it, yes, of course.
It's almost, your brain says, I'm in sort of encyclopedia.
This person's articulate.
Yeah.
Well, I mean, if they have an accent from the UK, you trust them a little bit
Even
more.
Well, especially from Scotland.
Especially from Scotland, exactly. Yeah, and I think we make judgments about the trustworthiness of the thing from a lot of cues, and one of it is the humanness of the language. And did it understand my human language? Yeah. And we've never had a technology tool that could do that. And so there is a risk that we will grant it undue trust. We've got to be very thoughtful about how do we test this to be sure it actually merits the trust that we're giving it.
Yeah, and that occurred to me the very first clinic when I used our Copilot system. You talk about the ambient or AI scribe. And I found exactly that. It was so beautiful. I almost sort of, my brain nodded off slightly as I was proofreading. And then I realized that, well, two things. One, it picked up something that I had forgotten from the conversation. So I was like, oh, that's great. If I was writing this note, I'd have forgotten to include that. But the second thing was it really did mishear or misinterpret something and put the patient on a drug that the patient was not on. And I did catch it, but I was 3 words past that before I realized I'd read something that wasn't true.
And that's the first time. Think about the 50th time when you've learned to trust the first 49.
Right. Yeah.
I mean, humans are quite bad at this. We are not built to remain hyper vigilant when we've come to trust a technology that has been right the last 100 times.
Yeah.
And so it's a really daunting problem. And one of the ways I framed in the book and in the grand rounds was if the technology was right half the time, it would be worthless. If it was right 100% of the time, that's great. I'm not sure what we're all doing for a living, but but the predicament we're going to find ourselves in for the foreseeable future is it's right often enough to be useful and wrong often enough that the human has to look over its shoulder. That's a task we were not built for.
Do you have ideas as to how we could program ourselves better?
Almost none.
Yeah.
Because I really do think it's very much hardwired into the human experience. I mean, there are some ideas. One is, and this is particularly true for training and preventing deskilling, that maybe we don't ask the tool to weigh in until the human has put its nickel down.
Okay.
In some ways analogous to the way we teach young attendings. Do not tell the residents and the students what you think. Tell them ask what they think before you weigh in. The analogy to the TSA, airport security, is they periodically throw in a picture of a bomb or a gun to make sure that the agents are staying awake. Should we throw in the wrong diagnosis or that wrong medicine into the note, and then we got to figure out a way of being sure it doesn't reach a patient? I think some of this is going to be more sociological than technological. It may be just making sure that our trainees understand the risk of being asleep at the switch. But I'm guessing in the over a long game, it's probably going to be more another AI looking over the shoulder of AI 1 than trusting that a human will remain vigilant when they become overly trusting of the technology. But it's a very hard problem.
Yeah. It is interesting that, and you described this well in the book as well, that the evolution we've had from the original GPT-2 to 3, where there was hallucination and the models were mostly using next token prediction. They weren't, for the most part, going to the source of the knowledge or information. But when we got into the RAG mode, which is the retrieval augmented generation mode, where it was parsing kind of real data, going to read the articles, if you like, or read the digital textbook, and then bring back the parsed version of something for real, and then provide the link to that. I thought that was a really interesting moment, because I think everything got better, first of all. There was less confabulation. You could also then click through to the link to check yourself.
Check the source, Yeah, it's interesting because, the advance there, for example, in healthcare is what do you get when you put in a clinical case into Gemini or into Claude or into GPT versus what do you get when you put it into Open Evidence, a tool that was built for medicine and uses as its main data source the medical literature and guidelines from the American College of Cardiology, et cetera. And the answer is, I think, a more trustworthy source using that, culled down literature. What is surprising, though, I have to say, is GPT and Gemini are actually pretty good. And they are using the entire internet, including PubMed, but also including The Onion and Reddit and everything. And it's a little bit surprising how good they are. I tend to trust the tools built for this purpose better than I trust the general purpose tools, but the general purpose tools aren't bad. I think one of the things that is fascinating and we don't emphasize enough, we spend a lot of time thinking about these tools as they come into medicine and health systems and doctors using them. One of the things I came away understanding better after writing the book is we have to think about patient-facing tools in a very different way. That the cognitive act of taking a data set of might be 50 items from a patient, symptoms, past history, medications, and culling it down to the thing that you put into the prompt box or the thing that the resident presents to his or her attending is really complex and requires expert level knowledge. Patients have no ability to do that. So a patient doesn't know of the 50 I woke up this morning, I have a headache and my foot hurts and I have a fever and I have a past history of this and I'm on this medication. Patient has no idea which ones are relevant. So having them use, and then on the output side, if it gives you an output and I look at it or you look at it and say, number 1 and 2 diagnoses, that makes sense and I hadn't even thought of number 1. But number 4, that's ridiculous. I'm going to pay no attention. Patients also have no ability to do that. So the tools for experts and the tools for non-experts really need to be quite different. And I think that right now you have millions and millions of patients using generic tools like GPT or Gemini, putting in their symptoms, trusting the results. Sometimes it's great, sometimes it's a little hazardous. I think we're going to have to develop better tools for patients that are probably going to act more doctorish. Meaning the patient says, I have a headache, and then the tool says, tell me about it, how long has it lasted, do your eyes hurt in the bright light, does your neck hurt? Back and forth the way a physician would, as opposed to just a generic chatbot where the patient has to be trusted to put in all the right information in the tool. I don't think that's quite ready for prime time.
If we think about the process of medical education, that's maybe the first thing we teach our medical students when they start.
I watch my daughter go through from being a novice to an expert, and it's very subtle, but really in some ways what you're learning is how do I take this massive number of facts and then cull it down to the thing I'm going to present to my attending on rounds. And that is, there's a lot that goes into going from novice to expert, and patients have not done that.
Well, and I think about a chest pain history being similar. Like we teach very early the questions to ask, but we do that in the context of limited time. I mean, ultimately, those questions are you want to leave space for the patient to talk openly, but then you need to drill down, and that's the skill we teach. The one thing these models have, and I think we could talk a little bit more about some of the data you presented on empathy, and some of it came from Stanford. But the one thing they have is essentially infinite time. Right? Which we do not. So how do you think that shakes out in the end? What is the balance there where we have, essentially infinite compute, infinite time to sort of talk, ask questions. How do we use those tools then and the benefits of that model along with there are a few things we both hope, I think, that are uniquely human.
I hope so. We'll see. I try to come into that question with some equipoise, recognizing I have a bias toward the humans because I am one. My daughter and son-in-law are physicians, and I it's too depressing to believe that everything we learn and all of the humanness about what we bring to healthcare has no value. That's depressing. On the other hand, I think we have to have a two-tailed test that says maybe there's some value there, but what if the machines get as good at it as we are and are more scalable, are less expensive, and are more convenient? Then they should probably win. You can imagine a world where, for example, think about the life of a primary care doctor. I've got 15 minutes to see a patient, and I've got 100 things to do, that the patient has interacted with a GPT-like thing before the visit. It has infinite time. Maybe the patient does or doesn't, but a lot of the questions have been asked, and then it's down to then delivering to me as the primary care doc sort of a relatively complete data set, and maybe even a tentative diagnosis that I then test. And again, am I going to be asleep at the switch, or am I going to be awake and really probe that? I don't know. We've got a lot of work to do to figure this out. the tests of AI empathy versus humans, you could argue are unfair.
Yeah.
Because when you look at why the AI does better than the humans on a measure of empathy, it was largely because the responses of the AI are longer.
Longer, right.
But that's not, in some ways, not unfair because the AI has infinite time and we
Right.
don't.
Yeah.
And so
That
is the real world. That is the test.
Yeah.
And so, don't know. I think one of the real interesting things that's going to happen, I think a lot about primary care because I think the predicament of primary care is awful. I think very few people go into it. It's underpaid, it's underappreciated, and the job is essentially impossible.
Yeah.
The patients come in with 10 problems on 15 medicines. I've got 15 minutes to deal with it. There was a study a few years ago that said if you only spent your time on prevention, that's 27 hours a day. That's if no patient had the temerity to have anything wrong with them. That's 27. Yeah. So how do you deal with that? Well, some of it might be the AI does some pre-work and then hands it to you. Some of it, though, might be, for the management of your blood pressure or your cholesterol, it's pretty algorithmic. Maybe that is all done by AI.
Right.
Now, there's a challenge there, which is if I'm a primary care doctor and I look at my schedule and the only patients I'm seeing are the wildly complex patients with social needs and massive complex. All the easy stuff has been taken off my plate by AI. I'm not sure that's made my life any better unless you give me enough time to deal with that and reimburse me in the right way. But I think that's the way this is going to shake out. That we're not going to fully replace primary care doctors, but we're going to say what are the things that humans can do uniquely, and what are the things the AI can do well and safely and more conveniently and probably at a lower cost, and figure out how to divide up the tasks that way.
Yeah, and I think we probably will be happier in that version of the world.
I think. I mean,
patients will be happier.
Patients,
probably.
I think so. Yeah. I mean, I am happier, as I mentioned. I will take a Waymo over an Uber.
Yeah.
I prefer to be in this thing that I know is incredibly safe.
Yeah.
And I can sing Springsteen at the top of my lungs in the back seat or take a nap.
Is that safe for everyone else?
As long as I'm alone, it's great. So I think we as human doctors may overvalue how much patients get out of seeing us.
Yeah.
And I think for the things that can safely be done by technology, if it can be done safely and conveniently and they don't have to take half a day off to see the doctor and sit in the waiting room, I'm not sure patients are going to be longing for the human touch.
Yeah.
But we've got to be thoughtful about that because there are some things where we don't want AI, I don't think, telling a patient they have cancer or diabetes or heart or kidney failure. And then so how do you divide up those categories in a way that actually works?
Yeah. It's interesting. I mean, Stanford is and UCSF, probably not globally representative of medicine, but it's now more than a year ago that someone called to get an appointment with me, and I think it was a few months before they could get it. So their follow-up question was, when can I see Dr. Ashley's AI?
Yeah.
And I mean, that's a genuine patient call. And my nurse at the time was like, I don't think we have that yet. But the idea that we would each have an avatar that actually is built like us, maybe it's actually fine-tuned at a minimum or trained on our records.
Oh, it will be. It will be. No, the book starts off in a scene where I'm sitting with the CEO of the Mayo Clinic, and he had on his computer something that he hadn't even shown to his board yet, and I could see, should I show it to him or not? And he said, the look on his face was, this is just so cool, and he turned around, and it was a Mayo radiologist speaking to a patient about the results of her x-ray. She had rheumatoid arthritis, and it showed it was a little worse. And he was wonderful and compassionate, and the patient seemed to value the conversation. And then behind him in walked the real Dr. So-and-so, who waved awkwardly to the camera. And as Jean Rico-Ferrugia said to me, 30 years ago when we wanted to scale the Mayo Clinic expertise, what did we do? We built a campus in Scottsdale and a campus in Jacksonville. He said, we wouldn't do that today. We would say, how do we take the Dr. Ashley avatar and make that level of competence and humanity and empathy available to more people? And it's not trained on the entire internet. It's trained on you and the last 10,000 patients you've seen, or the last 10,000 patients have been seen by great doctors at Stanford. I think that's inevitable and probably net good for patients. You think about, not only not being able to see a UCSF or Stanford doctor, but not having a cardiologist within 100 miles if you live in rural California.
Absolutely.
And now you have access to that level of expertise. That's pretty terrific.
Yeah. And I think that even, the USA has more cardiologists than I think any other country. So if you think about it on a global scale, the number of people who don't have access to subspecialty care.
I remember I was in Haiti a few years ago. They, I think, 2 oncologists in the entire country.
Right. Yeah, I think Alaska had 1 cardiologist. Yeah. Thinking about that and scaling of subspecialty care, there's also the question we talked a little bit earlier about scaling empathy. Mm-hmm. If we understand that people actually do treat, even though they know the model is a model, it's a computer, but they can still feel the benefit of that empathy, even although they understand at some level that this machine isn't feeling like a human, it's acting.
I've had discussions with my palliative care people about this, and they're kind of mixed about it. Yeah. But in some ways they say, you know, when we teach our students about empathy and an end-of-life conversation, or in some ways we're teaching them a formula. Yeah. It's like we're teaching, you identify with the patient, you reflect back what they said, you give them a plan, you don't take away their hope. Yeah. It's kind of pretty formulaic. Right. Now, you're starting with a human, and so they bring to the table whatever humans bring to the table in terms of empathy. You know, these machines have learned to simulate it, and again, they will begin taking on more human form. And you can imagine a world where people kind of forget that, you know, I'm not actually talking to a real human. And you're seeing that with some of the mental health chatbots, where there have been some egregious examples of horrible things that they've said that went off the rails and are cannot be defended. But there are millions of people today getting what they see as useful mental health counseling and coaching and advice. And you might say, that's awful, but try to find a mental health professional in Palo Alto or in San Francisco. And if you can find one, try to find one for less than $300 an hour. Right. You know, the Biden quote of "Don't compare me to the Almighty, compare me to the alternative." Yeah. And the alternative in lots of parts of medicine is, we have these great institutions and great people, but try to get in and see one.
Yeah, I think we raise the bar too high sometimes for technology. I think the quote encapsulates it beautifully. If your alternative is nothing, which it often is, then the bar for something is lower.
It should be, but then we do something which is predictable and natural, which is the bar should be relatively low if your alternative is nothing. And yet for a new technology, particularly one that people find weird and are scared about, particularly about their jobs, a single bad accident will become a cause célèbre. Yeah. And we saw this in San Francisco. It used to be there were 2 driverless car companies. There was Waymo and there was Cruise. Right. And 2 years ago, a Cruise car didn't actually run over one was hit by a regular car, but the Cruise then came along and she was under the wheels and it dragged her about 20 feet. And that company was out of business a year later. Yeah. And even though the data were quite clear that it still is safer than a car with a driver, but our tolerance for a bad outcome of a technology is very different than our tolerance for a bad outcome when a human's at the switch.
Involved. Yeah, I think that it just takes us to another sort of decision-making kind of regime in our heads. Yeah. One of the things I really liked as an aviation enthusiast, you often make comparisons between medicine and aviation, and often in those comparisons, and you're not the first doctor to have made those comparisons, but medicine doesn't come out all that well. But the reason I bring it up here is the deskilling issue. Yeah. And I wanted to talk a bit about that.
Yeah, well, medicine doesn't come out that well because I think aviation is a field that has really been incredibly thoughtful about safety and about integrating technology. And for the digital doctor, I actually went to Boeing and spent a couple of days with seeing how they think about cockpit design. When I told them that at UCSF there was a study several years ago that looked at the number of alerts that got fired by our bedside monitors in the ICU. Yeah. So this is when something is out of parameters for your heart rate, your pulse, your O2 sat, and the EKG tracing. In a single month in our 80 ICU beds, there were 2.5 million alerts fired in a month. Yeah. And a nurse I was interviewing for this said, the alerts are going off all the time. How do you? And I said, what would get you scared about something going wrong? She said, if there was no alerts going off, I'd be really worried.
Silent.
That's like Wacko World. It's upside down. Yeah. So aviation's been very thoughtful about the integration of technology, and it's demonstrably safer than it used to be. But there have been a few high-profile aviation crashes where the technology went on the fritz, and the pilots now had to fly a plane without their technological wingman. Right. And in a couple of very vivid cases, the most prominent being the crash of Air France flight off the coast of Brazil several years ago. The technology went wrong, they were flying through a squall, and the pilot had to make a decision about what to do and did precisely the wrong thing. Yeah. And when I interviewed Captain Sully about this, And he said the pilots were flying a plane that they were unfamiliar with, which is basically a plane without the technology. So deskilling happens very quickly. I think in medicine it's quite something we need to worry about quite a bit as the technology, if it's giving you draft diagnoses or draft therapies, how do we, or technologically enabled colonoscopy or surgery.
Right.
Now you might say, I don't care about deskilling because the tool is better than the humans, but what if you don't have access to it? What if it's not working? Or what if it gives you every now and then bad results? We had one of the radiologists at our place told me about a patient who had a AI-enabled CT scan, and it read the breast shield as the skin, and therefore said that the patient had bilateral lung nodules, which turned out to be her nipples. And that's the sort of thing that the AI will sometimes do if it doesn't understand the context, and having a human look in is helpful. But it's something we've got to think a lot about in our training world, because if we just automatically give the answer to our trainees, they will get dumber over time, and it's not their fault. We've got to figure out how do we prevent that from happening.
Yeah, I think we can feel it ourselves. I mean, those of us that you and I have both for the last couple of years, I think, pretty readily turned to these models to explore them and understand them. But I've caught myself recently in the last few weeks thinking, oh, maybe I should spend a bit longer thinking about this myself. For whatever it is. Sometimes it's, what's the name of that song? Or who was the person in that movie? Or, what are the fourth and fifth things on my differential?
You're a better man than I am.
But it's just,
the fourth or fifth things of the differential, I would say, yes, let me try to think. I don't want to de-skill. What's the name of that song? My threshold to go to GPT is 0. It's I'm not going to waste neurons on this.
Yeah, right. No, well, I applaud you for that. But at some level, I don't know. I mean, we think about our older patients and thinking about cognitive skills and thinking about trying to continue to engage their brain in everything, and even the novelty of learning new things, whether it's a new language or something as you go on. I do worry a little bit about that. There was the classic study with the brain scans, and I think the London cab drivers when GPS came in. And that was another example.
I mean, none of us knows how to read a map, and that's sort of reasonably useful deskilling. It's like, I don't have to. And you could argue we should all know, because what if, Google's down? It's like, that's not worth
we need the North Star. We need to a compass. This is how we get around.
We'll get by.
Navigating medicine is the thing that we're all trying to do. Overall, you're optimistic, I think. How do you see the next? It's dizzying how fast this moves. I mean, giving a talk, a month later on AI, I have to change a whole bunch of the slides. You have this really great kind of historical view in the sense that you've sort of analyzed different generations of medicine. So I'm really interested in particular, and we're here, this is the future of medicine. So we know where we are today, and it's somewhere that would have been hard for us to guess, I think, 2 or 3 years ago, certainly 5 years ago, no chance.
Great.
But even looking ahead 2 or 3 years, I won't say 5 or 10, where do you think we are, and what are the things that do change? And what are the things that don't change? You have the great story about Jeff Hinton saying that radiologists were going to be out of jobs.
In 2016, he said we stopped training new ones because it's clear by 2021 we'll never need any, and we can't hire radiologists fast enough.
Same here. We have a shortage. So we're clearly not great at predicting the future. At least Jeff, although he was great at many things and remains great at many things. At the moment, he's a bit of a doomsayer about the future, actually. But in terms of medicine, where do you see us in just 2 or 3 years?
I spent a lot of time thinking about this and interviewed over 100 people to try to get as smart as I could, and landed in a very optimistic place. Now, part of that is because the technology is unlike anything we had before, and part of it is because the system is so screwed up that I think we need it. And I think as I saw what this technology could do, in many ways it was perfect fit for many of the problems. In fact, many of them, as you said, were created by technology. I'm also sort of a student of politics. I was a poli-sci major in college. It's sort of how I think about the world. And I think part of my optimism is I think the most important incumbents in the health system are the doctors, maybe to some extent the nurses. And if either of those two guilds were worried about losing their jobs, they would push back very hard on this and would slow it down a lot. I don't think they are, and I don't think they should be. I think for the foreseeable future, the unmet needs are so profound that the technology will actually enable them to do their job better, and actually they'll be happier. And we see this in radiology, where the radiologists say, bring it on, I want this stuff. And they're smart, they know maybe 15 years from now, I don't have a job, but for now, I have to get through my day. So I'm optimistic because I think We're being smarter about how to implement it. We're starting with relatively low-hanging fruit where we're being successful, and that before we start on really ambitious stuff, because the incumbents are mostly welcoming it, because it's solving a lot of the problems in the health system. I think one of the big questions is, will it save money? We're really good at healthcare at figuring out a way of not doing that.
Yeah, exactly. We're good at spending more money.
At spending more money, and there, of course, is the argument that these tools right now are enabling us to bill better and keep our prices high and all that. But you can imagine a world where the tools, and this may depend on a change in the incentive system, but the tools driving us to deliver more cost-effective care, the tools lowering the administrative costs of medicine and all the bureaucratic stuff, and that probably does mean some layoffs in the billing department. You know, as I net it all out, I think that that it's net positive over what I see as the foreseeable future. 15 years from now, I still think it's probably net positive, but now you're in a world that's so far over the horizon that anybody speculating that I can predict. Think about, you know, what you might have said about social media as it was rolling out, and how nobody was predicting what it would do to education or to teenage mental health or to politics. This is going to have all sorts of effects that I think are hard to know, but it's over a 5-year time horizon. I think it's pretty positive.
Yeah. Well, thank you for leading us into the future. Thank you for writing such a compelling book.
Oh, thank you.
And thank you so much for visiting Stanford.
Always a pleasure. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.